Hello everyone. Today I'm going to be showing a presentation on developing an emergency department or ED care pathway for low back pain patients at the Duke University Health System. My name is Devan Desai and I'm an undergraduate here at Duke University as well as both a Margolis scholar and intern. And over the course of this past summer, I worked with Dr. Christine Gertz on this research project. And over the course of the summer, we developed this research poster, and in the next few minutes, I'm going to break it down into various sections. So today's discussion is going to go from an introduction to talking about low back pain patients in an ED setting, and then finally wrapping up with the care pathway that we built, along with some considerations and future directions. And before we get started, I think one key term that isn't very common that is useful to know is a primary spine practitioner. And that refers to any individual who treats conditions related to the spine. And for the purposes of this presentation, I'm limiting that to chiropractors as well as physical therapists. So to get started with a little bit of background information, low back pain and neck pain are the most commonly reported pain condition in the United States. They also have the highest financial burden on our healthcare system, with a cost of around $134.5 billion every year. Furthermore, about 75 to 85% of adults will experience low back pain at some point in their life, showing that it is a very common pain condition and definitely needs to be addressed. Now, more than 2 million patients go to EDs every year for low back pain treatment, making it a top 10 cause of ED visits. And unfortunately, patients often leave with more questions than answers, as well as a price tag of over $1,000 per visit. And studies have shown that in general, EDs are not well equipped to provide low back pain treatment based on current guidelines, which shows the need for a complex understanding and individualized treatment system. The special thing about low back pain is that it doesn't have just one cause for the pain, nor does it have one solution that can solve all types of low back pain, which is why an individualized care model is very important for patients. Now, to look at the research objective for this project, we wanted to see how we could develop a clinical care pathway for low back pain patients in the Duke ED. And a clinical care pathway refers to a set of recommendations that have all been built from evidence or results from studies that have shown some treatment or progressions that work for patients. And to start off with some of the methods, we started by looking at a review of the current literature to determine what exactly it is that constitutes an ED low back pain patient and what bothers them. From there, we looked at a review of clinical guidelines to determine what are the best practices for treating low back pain and what is recommended, as well as what's not recommended. And then finally, our next step is going to be consulting both ED and PSP providers for the revisions to this clinical care pathway. So just to look at some fast facts on low back pain patients in the ED, about 90% of those cases are going to be acute. Now, acute low back pain refers to short-term pain, whereas chronic low back pain refers to long-term pain. We also found that low back pain is responsible for about 4% of all ED visits annually. Now, low back pain could also be present as a comorbidity with other types of conditions in an ED setting, but low back pain was a primary cause for an ED visit in 4% of cases. Furthermore, we found that from 2006 to 2016, the cost per visit increased by 152% just for low back pain visits, which shows that over time, even as our treatment options have gotten better, patients are still paying more. Furthermore, many patients are still having pain at 3-month follow-up visits. And we've also seen that patients in the ED are being overprescribed opioids as well as having unnecessary imaging, both of which aren't recommended by many guidelines or evidence-based trials. So from there, we looked at some national guidelines, which are sets of recommendations provided by healthcare organizations or even whole countries. We found that studies in countries like Australia have a deeper understanding of low back pain than studies in the United States, and we found that compared to typical low back pain patients, ones that have to go to the ED often have a stronger need for pain management as well as more comorbidities. Red flag screening is also very emphasized in the literature, and red flag screening refers to when a physician or any provider is looking at a patient and determining if they have any other conditions that need escalated treatment right away. We also looked at existing guidelines which emphasize the need for primary spine practitioner referrals when appropriate. And then, for instance, we also looked to see how medications were being used. And on average, opioids were being prescribed 70 to 60% of the time during ED visits and about 39% of the time at discharge, showing that even though the guidelines and most of the evidence is against opioid use, they're still being prescribed at higher rates than they would be if the patient had gone to the ED setting. Now, based off of those reviews of both the guidelines and the literature, we came to this clinical care pathway. And just to highlight a few key things, we start off on the top left with a patient presents with low back pain to the ED. From there, they go through a patient history as well as physical exam before a provider checks for red flags. If a patient does present with red flags, a provider should consider admission, an urgent specialty referral, or even guideline concordant short-term pain management. Now, the Duke healthcare system, there's something special about their own imaging criteria, which is why the appropriate use criteria for imaging has been listed in this pathway. And going back to if a patient doesn't have a red flag, we're going to go down to considering guideline concordant short-term pain management, as well as looking into seeing if a patient has lumbar radiculopathy or unremitting pain. Based off of those screens, or based off of those conditions that a patient may or may not have, ED physician should consider PM&R, or physical medicine and rehabilitation referral, or even looking at a primary spine practitioner referral. One thing that's very important to emphasize is that conservative care options or non-invasive treatments should be emphasized for low back pain treatment. And if you look in the bottom left, we'll see that patient education as well as reassurance should be emphasized throughout the entire pathway. So now to look at some considerations in future direction, over here at the Duke University Health System, both spine health and ED physicians are working on a system that can provide high quality and guideline concordant care. We found through multiple studies that conservative care options have been shown to have a positive impact on the patient experience and on the outcome as well. So they've been emphasized in that pathway. And moving forward, a draft pathway will be shared with ED and PSP spine practitioners through a Delphi review process, in which their own recommendations will be taken into consideration before building out a model that can be utilized here at Duke. So with that, I just wanted to provide a few acknowledgements to people who have made this research project possible. So a big thank you to Dr. Desai and Tiffany Chen with the Margolis Internship Project. Also a big thank you to Geronimo, who provided a lot of feedback throughout the entire process on the care pathway. And finally, for their guidance and support overall, I just want to thank the Duke Spine Health Executive Committee, as well as the Duke-Margolis Scholars Program. References for this project can be seen at that link or by clicking that QR code below. And if you have any questions or want to get in touch, you can reach me at devan.desai@duke.edu. Thanks again for coming to this presentation today, and I hope you have a great rest of the day.